Okay, let's get into this. We're looking at a specific medical protocol today.
Right. It's for patient care immediately after a carotid endarterectomy surgery.
Exactly. Think of it like the playbook the medical team uses in those crucial first hours and
Yeah,
days.
that critical post-op window.
So our aim here is to pull out the key instructions, the main steps, to really understand what that immediate care plan looks like.
Makes sense. It's all about understanding the details in that guideline.
So day of surgery day and heading into day one, what's the absolute top priority according to this protocol?
Well, the immediate focus, the real core of it, is managing the patient's blood pressure, physiological stability.
Okay, blood pressure. Is there a specific target?
Yes, very specific. They aim for a mean arterial pressure, the MAP, between 70 and 100 mmHg.
70 to 100, that's a clear range. So what if it, drifts if it goes too high?
If the MAP goes over 100, the protocol says use nitrosine titration.
Nitrosine,
Yeah,
that relaxes blood vessels.
exactly. And titration just means adjusting the dose carefully, bit by bit, to ease the pressure back into that target zone.
Right, gently bringing it down. Okay, but what about the other way? If it drops below 70, that seems like it would be a major concern too.
Oh, absolutely. And here the protocol gets quite interesting. It's not just one single action.
How so?
If the MAP is under 70, the first thing you do is check another vital sign, the central venous pressure, or CVP.
Ah, the CVP. That gives you an idea about fluid levels, doesn't it? Pressure in the big veins going back to the heart.
Precisely. It helps figure out why the pressure is low. So if MAP is low, and the CVP is also low, say less than 10 centimeter H2O, it suggests not enough fluid volume.
Like the tank's a bit empty.
Sort of, yeah. In that case, the instruction is a Ringer's bolus. Give IV fluids, specifically 250 milliliters per hour, to boost that volume.
Okay, low pressure, low CVP, add fluids. Straightforward enough. But what if the MAP is low, but the CVP is actually high, say over 10?
That's the other branch. Low MAP, but high CVP suggests the issue isn't volume. It might be vessel tone or the heart itself.
So different cause, different action.
Exactly. In that scenario, the protocol directs the team towards noradrenaline titration.
Noradrenaline. That constricts vessels to raise pressure.
Yes, it's a totally different approach, chosen based purely on that CVP reading. It really shows the layered decision-making here.
That's fascinating. Using one reading to guide the response to another, really detailed.
And there's a crucial warning, too. Watch for hematoma in the neck. Any sign of that, contact the doctor immediately.
Right, a potential complication. Okay, so besides blood pressure and that warning, what else is key right at the start?
Well, oxygen is mentioned usually in O2 mask. Yeah. And keeping an eye on blood count, specifically hematocrit or HCT, needs to stay above 30%.
Oxygen, blood count. Anything else practical?
Yes, a chest x-ray, a CXR. That's needed to confirm the CVP line we just talked about is actually in the right place. You need accurate readings.
Makes sense. Gotta trust your measurements. What about lab tests? Is there a schedule for those?
Yep, clearly laid out. Day 0, the day of surgery, it's HDT again, and TROP-T.
TROP-T, troponin T. That checks for hurt stress or damage.
That's the one. Interesting, they check it right away.
And day 1, more tests.
Yeah, day 1 expands things. You get UKE, that's electrolytes and kidney function. FBC, which is a full blood count, CRP for inflammation,
Okay.
and TROP-T again. Sort of a follow-up cardiac check. Gives a wider view of how the body's responding.
So day 0 checks, then broader checks on day 1. What about the patient experience? Eating, moving. Does the protocol cover that?
It does. Quite specifically. Day 0, the patient can eat and drink, which is good. Helps feel a bit more normal.
Yeah, definitely. But movement.
Day 0 is strict bed rest.
Yeah.
And usually in what's called a semi-Fowler position.
Sitting up slightly, like 45 degrees.
Roughly, yes. Helps with breathing, comfort, but definitely bed rest.
Okay, bed rest day 0, then day 1. Big change.
Big change. The instruction for day 1 is simply mobilize.
Wow, just like that. From bed rest to mobilize within 24 hours. That's quite a shift.
It is. And when you look at all these steps together, the blood pressure targets, the labs, the shift from bed rest to moving.
What's the takeaway?
It just highlights the intense monitoring and the very structured step-by-step approach needed right after this surgery. It's about navigating that initial vulnerable period really carefully.
So to recap, based on this protocol, we've seen the tight control needed for blood pressure, the specific labs for day 01, and that clear progression from eating but staying in bed to getting up and moving the next day.
Right. It offers a glimpse, really, into how structured and vigilant that immediate post-operative care has to be. It's all about responding quickly and correctly.
This protocol lays out a very clear path, taking the patient from the operating room through those first critical steps towards recovery, ending with that mobilizer's order on day 1. But, while the protocol gives the instructions, what unseen things, maybe individual patient factors not listed here, might affect how smoothly someone actually makes that transition from bed rest to mobilize?